Priorities MCQs, so the big things people get wrong are not working order of A, B, C, D, E. I'll explain what I mean shortly by that, but essentially there might be multiple correct answers in the scenario. So it might be, a climber's fallen, he's got X, Y, Z injuries, he's on the floor snoring, he's got an open cut to his forearm that's oozing blood. He's got a femoral fracture, and what is a priority? What would you do next? And the answers might be a range of things like treat his traction, apply traction to his leg, urgent evacuation, secure his airway by stopping him snoring. And the purpose of this exam, the answer would be whatever comes first in that ABCD, so the answer would be stop his snoring, which is that urgent A problem. You clearly need to do multiple of the answers correctly, but it's all about trying to get the sequence in your head. The same reason we like this idea of sequencing and establishing like a hierarchy by treatment control. So if someone's got a bleeding point in their arm or a leg, we don't just go straight to a tourniquet. If someone's, if we're concerned about someone's airway, we don't immediately necessarily go and just straight away just put a Goodell airway down. We might want to work our way up the process and see what's working and what's not working. So for hemorrhage control, we might want to do some simple pressure, maybe elevate the leg. For an airway, we might want to do a simple adjunct. We may want to look for a potential reason why that patient is unconscious. Looking for things like opiate overdose or hypoglycemia. So start at the basics and work your way up the treatment ladder. Hypothermia guidelines always come up. There's always one or two marks there, which I will try and go over tonight. There's a couple of double negatives, and unfortunately, a lot of these questions are written by people like Muggins here. We've all got the ability to be a bit of a dope at times, and by that, there can be some slightly strangely worded questions. And there will be a couple of questions on that exam. I know that Jill can testify to this because she's the most recent person to sit an exam here. But there's some questions on there that really will potentially throw you. But don't worry, expect that to happen for a couple of questions, and don't be too concerned. And then medications. So they might give you the right medication. So for example, they might have someone who's having an asthma attack, and they might give let's do something easier. I don't know. They might have someone who's having a heart attack, and they might have low saturations, and they might talk about what's the best treatment, and they might go asthma 300 milligrams, that's right. And then they might say, well, oxygen at 7 litres per minute. And now oxygen, if someone's got low saturations, would be correct, but we also know that's a strange flow rate, so that isn't the flow rate that you're used to using, so that answer would be wrong. So sometimes with medications, it's about looking at the very specific things, like if the medication dose doesn't look right, even though the medication itself might be right, then that's probably the wrong question. So go on, let's start off by asking you some questions about drugs on the formulary. So no doubt you might be a little bit rusty here. But here's a question that could easily come up in your exam. So, what's an exclusion criteria for taking aspirin? So firstly, who would? I mean, this isn't just a Mike and Mike. This is, you're all obviously joined in. So please, happy to make this as interactive and chatty as you want. But when are we going to give aspirin? For what reason are we going to give someone aspirin for use of us in our team?
Heart attack.
Suspected MI.
Yeah, exactly. So anyone who's had any form of pain in the chest that we're concerned might be related to the heart. Whether they had it an hour ago, they've got it now. If we're attending for the first time, we're going to give them aspirin. So run me through these. Who wants to take me through these? Mike, Mike Jones, go on. You run me through these one by one. What do you reckon to these ones?
You want me a bit bigger on screen? So, contraindicated to children under 16, I think.
Yep.
Previous, I think that's the only one.
Would anyone disagree with that? Silence. I don't think either of you did disagree.
No.
Exclusion.
Agree with Mike.
Yes.
Yeah. So and this is often the type of slightly strange question you've got to get your head around for the exam. So which of these is an exclusion criteria? So it's not quite a double negative, but you've got to correct yourself already. Which of these can this patient not have? And you run them through. And child under 16, you're right. In the formulary it says anyone under 16 can't have it due to potential condition called Rey syndrome, which you can get if children take this drug. Cardiac chest pain, well, we know that's not an exclusion criteria. Already taking a baby aspirin, so a lot of the population might be taking a baby aspirin for a variety of conditions. If they're already on one of those, we can still take the bigger dose of aspirin, so don't worry about that. Previous allergic reaction to paracetamol, and brother has an allergy to aspirin. These two questions I put in intentionally because they really, really throw people. Because obviously the big thing we want to avoid is an allergic reaction. Dave Albright was just sort of popped in the chat box that there is this the website, well, not the website, but the British National Formulary, which used to provide a book once a year that used to litter hospitals and GP practices. They also have a really useful website that is littered with all this stuff, and they've got really in-depth details about all sorts of drugs, and that's free to access online. So if it's something really obscure, you'll be able to get that kind of allergic reaction information from that. If you're uncertain, you ring me or Theon or any other healthcare professionals who you want to ring. But the Mountain Rescue Formulary does have most of these things on. But things like these allergies, people are so frightened, and understandably so, because we do drill it into you about missing the allergy, that things like if they've had a reaction to something like paracetamol, aspirin, and ibuprofen are all completely separate drugs. So just because you have a reaction to one doesn't necessarily reaction to another. And it's important to try and remain confident with that kind of thing. But if you're uncertain, ask in real life. For the exam, though, you're going to have to commit to this kind of stuff. Brother has an allergy reaction. Well, I guess that might technically slightly increase your risk for having an allergic reaction, but the reality is that that isn't contraindication. Any questions on that? So here's a particular favourite of mine. Ibuprofen, a drug that no doubt many of us use, but I don't know what Dave's experience is, but I mean, I personally am not a particular fan of using these types of drugs in clinical practice. They definitely have a use, and I use them on myself a reasonable amount. But what I'd like to do is just go through one of these one by one. There's one patient here who's a good candidate to have ibuprofen. Ibuprofen is obviously a relatively innocuous drug. You buy it over the counter. A lot of people will have it in their own drawers at home. But this question is set up because there's only one of these patients can have, as per our formulary, only one of these patients can have ibuprofen. So just as a group, let's go through them. So someone talk to me about this first patient.
The only thing I'd say with that first one is the heart rate could indicate some other drug that they're on.
Okay.
Maybe warfarin or something, which would be contraindicated.
Anyone want to add anything on that first patient? So all these questions are taken directly from the Mountain Rescue formula. If that makes sense. So with the formulary in hand, you can answer the questions. So you answer those questions. Anyone else want to add anything? I thought Jill briefly unmute herself.
Yeah, I always kind of, if I was 9 out of 10, I'd want more than ibuprofen, and I'm thinking, are we moving towards shock symptoms here?
Okay. So 2 really good points here. So number 1 is is ibuprofen we want something stronger. That is a very fair point, but let's not forget the purpose of the analgesia ladder. So it's really important to layer our pain relief step by step. So the more different types of drugs that we can put in, the better the overall analgesic effect would be. I think in the right patient who's got 9 out of 10 pain, I would 100% be giving ibuprofen if it fitted for them. The reason for this is that Matt Nash's formulary states that anyone who's shocked cannot have ibuprofen. And the reason for that is it can cause issues with the kidneys later down the line. Nothing to get into in terms of being too scientific, but shocked patients don't get ibuprofen as per our formula. So next patient who wants to have a chat about this? Anyone? Don't worry about getting anything wrong. The whole purpose is if you get it wrong, it actually makes things easier because it gives us a discussion point. You get a bit boring thing that sounds right all the time.
You just mentioned the kidney problems, and this patient's got kidney disease. So is that contraindication?
Yeah, definitely no for me.
Yeah, so as per our formulary, people who have got chronic kidney disease don't take the drug. Obviously, the reality of life is a bit different, but as per our formulary, if you've got a history of kidney disease, you shouldn't be taking it. 24-year-old female who's pregnant, an ankle injury, 8 out of 10.
Definite no for me.
Anyone disagree?
Why is that?
Pregnancy.
Is that a contraindication? Is it?
I think so.
Yeah, it is. So pregnant women, pregnant women generally the variety of drugs that we have available to them are less, and paracetamol is a safe bet for pretty much anyone. Morphine is a reasonable safe bet for most people for pain relief. They obviously do have their individual things, but pregnancy, check and double check. Certainly, this category of drug, ibuprofen, is not suitable for pregnant people. I've got my terminology right. The next is 19-year-old male who's got epilepsy, got ankle injury at 8 out of 10.
I can't see why not in my head, but it's when I look at that list, it's probably the most appropriate candidate, but it's quite a hard judge on all of them, I think.
And this is the thing is that you know there's one right answer here. So if we go on to the last one, what are your thoughts about the last one?
Definite no for the asthma.
So that's a definite no. So it takes us back to the previous one, and I put epilepsy in there just because it makes people think it's comorbidity. We don't want to give people who are epileptics drugs that can change their threshold to have a seizure. They have a seizure and a whole load of fresh new pickles. So I put that intentionally just to try and throw people. There isn't any issue between ibuprofen and epilepsy. You've got an ankle injury, you've got significant pain. This is a really good case to give someone ibuprofen. Any questions on that?
Nope.
No.
We won't spend too much time on this kind of stuff. I actually put this in rather cheekily in the last one because the last examination had a patient who had abdominal pain, which I thought was really, really unfair. So you know how we have medical scenarios and trauma scenarios? Well, actually, the last set of exams had a patient who had abdominal pain, but it was a medical scenario, so no trauma. They suddenly developed severe abdominal pain, and the medics who writ this scenario were sort of saying that the Cascare should be considering things like an acute gallbladder infection and appendicitis and a ruptured bowel, I think it's completely inappropriate that we're starting to work at that kind of level. But whatever. But the reason I brought this in is because actually they wanted us to give Bucostem, and that was a really important point about if someone's vomiting, regardless of the cause of vomiting, whether they've got D and V, whether it's because we've given them morphine and they're vomiting, whether it's because they've had an allergy and they're feeling nauseous or whatever. Actually, we've got a really effective analgesic here, so there's no reason why we can't give it. And the main reason that I put this in was because I was trying to sneakily help the last group to be aware that I probably shouldn't have done it, but that Bucostem is a drug that can be used for whoever. And this is all sort of formulary-based questions, so there's no point just reading out the formulary to you, but essentially the question here, two of these scenarios are correct. One is alongside morphine, and you do that when you call outs, I hope, give Bucostem hopefully liberally when you give morphine. I would say that the majority of our patients who get morphine get put in a stretcher, get carried somewhere, then get put in one of our highly comfortable Land Rovers. They usually end up yakking at some point along the journey. So alongside morphine, let's be liberal with giving that. Abdominal pain and vomiting in the 40-year-old. That was actually the scenario in the written question that I was trying to lead them towards. So if someone's, for whatever reason got nausea and vomiting, feel free to use the Bucostem. And then this question was directing us back towards the formulary, because it can't be given to epileptics because that does affect their seizure threshold. And it shouldn't be given to children, I think, less than 12 or 14 years old. I can't remember the exact age, but children shouldn't be getting study.
Just on that one, Patrick, do you know which book the question, or what the questions for the written paper done from? Which edition?
So they are. I mean, they're not really written from anything. They're written from the depths of people's brains. There's no real. It's structured around our syllabus.
Mm-hmm.
So if you go through the syllabus and you're with the syllabus and you see an area you don't know about, that's probably the best way to identify your learning. But there isn't actually a specific book. There is the revision guide, the Langdale revision guide, which I think I sent round to you on the original set of emails. That's got lots of generic information. It's worth reading through that, and that's where a lot of stuff will come from. But I don't think there's a fix of textbook based stuff.
Yeah, it's just I was on one of the books I was reading a few weeks ago. It said don't give oxygen if saturations are less than sort of 96%, and then we've always talked about it being 94, 95%, and it was just it's just for which version do we go with for written paper where it's black and white technically.
Yeah, so unfortunately there is a lot of sort of very slight alterations between different teaching methods, which I'm afraid are confusing. I think the formulary refers to 94%.
Okay.
And the formulary is the most up-to-date document that gets changed about every 2 years. All the textbooks, I suspect they've not been touched for, I don't know how many years.
Have you got access to Moodle, the Moodle stuff?
Oh yeah, that's a very good point actually.
Oh yeah.
Have you seen that, Mike?
Typically not used it for 3 years, so yeah.
Yeah, no, that's a very good point. It is a really good resource. If you get yourself a login for that, the Cascare lot, I don't know when they did it, but they chucked on a lot of resources on there.
Yeah, they have. It's where I went to in the end with my revision, because the books were so out of date, and I ended up getting really confused because I had the Numero Cascare card, I had the Flamberis Cascare card, the books, and everything was saying something really different. So in the end, I just went to Moodle and went through everything that was on there. There's videos and everything on there.
Jojo, thank you.
Gases, we kind of talked about, but just sort of quick fire question. So, what's the right oxygen setting for trauma for oxygen? As in, what's the flow rate?
15 litres a minute.
Yeah, for nebulizing.
Right.
Yeah, about I think it's like 6 to 8. I think they say they usually give a bit of a gap. 6 to 8. Entonox. What's the common? I know there's a few exclusion criteria, but there's a common exclusion criteria.
Head injury.
Chest injuries.
Yeah, so head injury is okay for Entonox.
All right.
But it's chest wall injury, because it affects the I don't know how to phrase it. My physics is useless nowadays, but essentially it allows it's a lighter gas, so it's able to pass into
Permeability.
Yeah. So it can basically, if you've got a punctured lung, it can escape into areas it shouldn't escape into. I think is an
Diving as well, isn't it?
Sorry.
And diving as well.
Yeah. So I think there's a history. I think it's either basically if you're going to dive 24 hours before or after. I can't remember which way it is. Go to I think it's only diving in the previous 24 hours.
Yes.
Adrenaline. So this is the classic type of question for an exam. So in allergic reaction with airway swelling, when in the primary survey do you give this?
Anywhere.
Yeah. Oh, sorry. Not when in the body. When in the sequence of the practice of CABCD.
Hey.
Yeah.
I mean, isn't it? Yeah.
And in case Clive's comment was about anywhere in the body, it's always
No, it wasn't.
No, it wasn't. Okay, fine.
I was just thinking it's such an emergency. That's what I was thinking of.
Oh yeah, no, that's true. Yeah, no, okay,
So anywhere in the sequence, really, that it occurs.
Yeah, so thankfully an airway comes up pretty much straight away once you check catastrophic bleeding. So for that purpose, we're going to get adrenaline pretty quickly. Don't forget, from a safety point of view, adrenaline has to be given into a large muscle group such as the shoulder or the thigh, because it causes the blood vessels to constrict. So giving it into a finger or a hand is really quite dangerous stuff. A couple more questions on drugs, and then we'll move on to some more clinical scenarios. So go on then. Let's go through. Let's go through some of these questions. So for GTN spray, when is the right time to give it? So there you go. You've got. So one of these is the correct answer. And if you run through them and explain, out loud why an answer is right or wrong, just so that we can sort of discuss that.
So I think you can rule out 3 of them myself, which leaves you with 1 left.
That's fine. How are you getting on, other Mike?
So, yeah, I think the first one you probably GTN's not, you're way past where GTN's going to be of use, I would have thought.
So what's the concern about GTN with that first patient?
For me, it's potentially low blood pressure.
Yeah, you don't really know what the problem is with that person with that information.
Yeah, potentially. So, I mean, a heart attack definitely could give them chest pain and could make them shocked, barely palpable pulse and cold and clammy. But I think again, in mountain rescue, in MRAW speak, this sort of cold, clammy, barely palpable pulse, this all indicates shock and low blood pressure. Those are like the big key words for it. So if you're cold or shocked and you've got low blood pressure, then any drug that's going to lower blood pressure further is, by formulary definition, needs to be avoided. And the main drugs that we've got are so GTN, and what's the other one that we avoid? Always catch people out in the exam. What other drug do we not give to someone who's got signs of shock?
Morphine.
Yeah, morphine. That's something that comes up in the exam, in the practical exam, quite quickly, where they try and where you've got someone who's got a big had a big traumatic event. They're in lots and lots of pain, but they've got signs of shock, which might be a weak or thready pulse, fast heartbeat, low blood pressure, and they try and get you to give morphine. If you do, unfortunately, because that's the formulary definition, ends up being fairly similar.
So just on that, Patrick, there's always one that's like a bit of a weird one, because if they've got a GCS of 15 and they're in massive pain from a trauma, and it's sometimes hard to get shock symptoms correct, what else could you do for them in that situation?
So we're talking about so again, it's always important to differentiate between real life and the exam.
Mm-hmm.
General principles are paracetamol, splint the leg, Entonox. These are all useful ways of giving analgesia without giving anything particularly potent. Splinting, especially for a leg, is very helpful. Once a leg's been broken, but it sort of gets itself settled in a position, it can be quite comfortable. And Entonox, I know that we bang on about the fact that Entonox is not being used as a long-term pain relief. It does have its uses, like this. You may rely on it slightly more in this situation because you've got so little else. In the exam, it will be clear whether this patient is shocked, because the examiner will tell you when you feel the pulse, and you'll feel the casualty's pulse, and obviously the casualty will have a pulse that's probably about 60 or 70 or 80 beats per minute, because they'll probably be a well person. The examiner will then say to you the pulse rate is 130 beats per minute, and the pulse feels quite weak. So they are being forced to direct you to tell you that patient is shocked. That is examiner speak for shock. Okay. And once you hear that, then your hands are bound. You don't give morphine because it's a tick-boxing exercise. In reality, in real life, there's maybe a little bit of leeway. You would assess other factors. You would get someone maybe a bit more senior to come in and make an assessment. So I would never want to say things black and white in real life, but for the exam, as long as you do your primary survey, you'll get all the information you need to tell this patient shocked. Because if you take a pulse and you comment on the quality of the pulse, the examiner will have to correct you to what the actual findings are, and that way they're essentially telling you they're shocked.
Yeah. No, it's always one of those ones that's, you imagine in real life, if you had someone who's really smashed up from a big climbing fall, and they're massive pain, but they are not bashed the head, and they're GCS, full GCS, and they're in huge pain. What do you do to, you can't just package them up when they're in so much pain, and even with ibuprofen.
I think, obviously we wouldn't be able to give ibuprofen for the same principles. I would say that if it was me in real life, I would probably just have to make a judgment call at the time. I would splint whatever I could splint. I would get them so immobilized, anything that's broken can't move. I would give him oxygen. I would potentially give him lots of Entonox if I needed to. I'd definitely get some paracetamol in there early, and I would make a judgment call about giving them some morphine as well. It's the reality of what we do. But we give them some morphine. People take a lot of morphine to kill pain properly, and it is entirely likely that they're going to be in pain if they're that smashed up, and sometimes the best thing you can do is just smash and grab and accept that although it's horrible, you just take someone who's in pain, get them packaged up and just run. Because from my experience, our team can actually move very, very quickly in this kind of scenario when it needs to. I've seen people be packaged up very, very quickly, especially when there's the threat of a helicopter nearby. And actually the reality is that I think we can package people up very, very, very swiftly, and it will be about the Cascare to direct the rest of the team to ensure that that's what the priority is.
Yeah. No, fair enough.
Anyway, I'll go through these answers just for the sake of time. So history of chest pain, now cold, clammy and barely palpable pulse. The answer to that is no, because they've got low blood pressure, they're shocked. Okay, so we're not going to give an agent that lowers blood pressure further. Ongoing cardiac sound and chest pain with a heart rate of 90 beats per minute and good radial pulse. That's what GTM was written for. That's the ideal patient. Trauma with injury to chest wall causing pain on breathing. Now, what I'm getting at here with that question is that this patient has got musculoskeletal chest pain. They've got a structural damage to their chest wall because of trauma. GTN does not treat that pain. It's got no use whatsoever for it. What they need is paracetamol and ibuprofen, and morphine. That's what they need. They don't need GTN. GTN opens up the arteries in the body and helps blood flow. That is not going to treat that kind of pain. And then finally, 45-year-old person with chest pain has erectile dysfunction. What's the key there? It's the one that most men seem to be able to remember.
Viagra.
Yeah, so Viagra. If you had a Viagra in the last 24 hours, then the formulary advises that GTN is not given. Quickly on midazolam. Midazolam, 18-year-old. He had a seizure 30 minutes ago and is now drowsy. They've stopped seizing. Do we give midazolam to that patient?
If they stopped, no.
Okay.
No.
That seems like a fair response. So they stopped seizing, but they're drowsy. What do you think about that?
They're exhausted.
Respiratory depression anyway. You don't want to give them something that's going to increase that.
Yeah, that's a fair point. And yeah, I mean, I think this is what happens when someone's had a seizure. They have what's called a post-ictal. I don't know if anyone's experienced or knows anybody else who's had a seizure, but they often get this post-ictal phase. The brain, just like any other organ, if it experiences significant activity, and essentially a seizure is just overwhelming electrical activity. It's this sort of whole network of electrical signals flying across the brain, and then it leads to really intense muscle contractions. So the body and the brain is physically tired. So they're often drowsy and sleepy after they had a seizure. They may even be snoring. They may actually need some airway support after a seizure. And over a course of minutes, that will slowly improve. But the main thing is, as Mike said, if they're not seizing, they don't need GTM. They don't need midazolam. 18-year-old epileptic, ongoing seizures of 6 minutes duration. Do we give that 18-year-old some midazolam?
Can't see why not.
Yeah, that seems to be the.
Yeah, seems right.
Yeah.
And I mean, and sorry, there isn't only one correct answer. Well, there might be, who knows? But then, and then the last question: 24-year-old post-traumatic head injury who's been seen in 5 minutes.
I can't remember. I think head injury does cause seizures, so why wouldn't you? Is my logic.
Yeah, so I think the originally head injuries were excluded from the formulary because the mechanism of seizure is slightly different. But I think that's now changed, and if you have a seizure after a head injury, it's clearly a very worrying sign. It suggests there's been some significant injury to the brain, but the end result, regardless of what's causing it, is the same. The patient is now seizing. It may not be an epileptic seizure, due to an internal problem within the brain. It's because of external injury to the brain. But they've still hit that 5-minute threshold. They're still seizing, so let's give it. Okay, this is a big one. Nexus criteria. This is one that Jill unfortunately fell foul of my negligence last exam. Just want to keep in your brain and go over in the days running up to it and be aware of it. The Nexus criteria is essentially a criteria that we can use to clear a C-spine. So if someone who's had a head injury, there is this tool that we can use to make sure that rather than we necessarily mobilise the spine and get them committed to a rigid stretcher out, that we can actually clear it on the hill. And this is it. So that they've got to have. I always find it difficult to work out how to describe this. So in someone who's had a head injury, in order to clear it, they have to achieve 5 ticks. Tick number 1, they need to have GCS of 15 out of 15, so they need to be fully conscious. Tick number 2, they need to have no midline C-spine tendons. So what does that mean? So if you run your fingers along your spine in the middle of your back, you'll feel that bony ridge. So that section from the base of the skull up there to the top of the shoulders, if that's tender when you press the bony part, not the soft squidgy muscle either side, but the bony part in the middle, if that's tender, they've got midline C-spine tendons, and therefore you can't clear them. If they don't have pain, that's a tick. Third tick is they can't be drunk or under the influence of anything else. Tick number 4, they can't have weakness or pins and needles or any of their arms and their legs that might indicate some damage to the nerves in their neck. And the final tick is that they mustn't have a distracting injury, so significant injury elsewhere in the body, whether it be an open wound in the leg, or, broken arm or something. Okay.
So that's right. That doesn't have head injury part. That's not.
Sorry, that was me messing around
Right.
originally. So I think my point from that was that you don't need to clear someone's C-spine if they've not had a head injury. Was the way that I worded it on my first time I mentioned it. But essentially, if they had a head injury and you want to clear a C-spine, they've got to tick all those 5 points, and that comes up in the written exam as well.
That's right.
As Jill can testify, it comes up in the practical exam.
Yeah, I just remember there being 5 things, and I was just wondering whether there was 6.
So go on then. Why don't we go through this question? What do you think about this?
So the first most important step is elevate the leg and apply direct pressure. I think the others are things you do after you've tried that initial treatment.
Anyone want to disagree with that? No. Yeah, I would agree with that. So that's working our way up the hierarchy, isn't it? So, what's the first thing you can do? What's the quickest thing you can do is you can get something, whether it's sterile or not. If you see someone who's bleeding, depending on the severity, you can just get some material over it and apply pressure. I think that's a good. Yeah, I'm happy with that. And then next, you might add a hemostatic dressing. Then if that was struggling, you might apply a tourniquet. And then obviously everyone needs to be immediately evacuated in that situation. Apply indirect pressure. I don't think we really teach it. Well, I certainly don't really teach indirect pressure. Do you know what we refer to by indirect pressure?
It's like a fist into the groin to find the artery, isn't it?
Yeah. So if direct pressure is pain on the site of bleeding, indirect pressure is obviously not pain. Pressure on the site of bleeding. Indirect pressure is pressure somewhere else away from the bleeding site that will reduce the bleeding. And the way you would do that is you would compress the arteries that are supplying that area with blood. So if it was a big leg bleed, if you compress the femoral artery in the groin, then you can technically reduce blood getting to the groin. I mean, it comes up in the exam, but we don't teach it because then you have to start learning where all these other pulses in the body are. So I won't worry too much. I think that I'd be surprised if the correct answer was ever indirect pressure, because we can always apply a tourniquet if needed. A tourniquet is potentially more damaging than indirect pressure, but as far as I'm aware, we don't teach indirect pressure to any real degree. Types of shock. So there are kind of 4 main types of shock, but the 2 that you need to be aware of are these 2. So hemorrhagic and anaphylactic. Hemorrhagic is where you lose blood. So you've lost blood. So if you've got the circulating system of fluid that's being pumped around by the heart, if you lose the volume, then then the pressure drops, and your heart rate has to increase to pump that smaller volume quicker, so it completes the circuit more times. So basically, in all kinds of shock, your pulse rate is going to go up, your blood pressure is going to go down, your SATs might be, your SATs might be unchanged. Your SATs might not change at all. Your respiratory rate is often the first indicator of bad things going on. So your respiratory rate will often go up as well. Respiratory rate, if respiratory rate is high, it doesn't necessarily mean it's a B problem. Respiratory rate will go up in most events of sort of someone generally being unwell, and often it's the first parameter that starts trending upwards. In anaphylactic shock, they're often hot and flushed, and in a hemorrhagic shock where they've lost blood, they're often cold and clammy. What have we got here? So a biker falls down a steep rocky section on dangerous ground, and approach from a distance. You can see that they're unconscious, with laboured breathing, with heavy blood loss. What's the next step?
Danger.
Yeah, I'd go with that.
Anyone want to disagree with that? Yeah, again, this is a very typical exam question. It lures you into the desire to get your hands on and do things that will improve the casualty, but the question clearly states the ground is dangerous. So in MRAW speak, that means, yeah, what's the first part of the primary survey? It's dangerous. So once you've cleared that, you can't go any further. What else have we got? Did we do this question? I feel like Mike, have you? Well, either Mike, have you seen this question before?
No, I don't think so.
No, I feel like Jill might have, I'm afraid. So here's a question. So you review a lady who's tripped. She has swollen ankle and appears in pain. You can smell alcohol and she appears unkempt. She keeps repeating herself and doesn't seem to remember what you're saying. She does not wish to go to hospital. What do you do next?
I guess police is the only option for me, I think.
What do you think, Mike? I mean, not that you want this job to be turfed to you.
Force her.
Yeah, it's the keeps repeating herself and doesn't remember what you're saying, which makes you think she possibly doesn't have capacity to make good decisions there. So, yeah, you'd want some assistance from the police for that, I think.
Sorry, Dave. I think you unmuted briefly then.
Yeah, I did. Sorry, I was just being flippant. She's already in the cas bag. Force her in the cas bag, but I am being flippant.
Is she in a cas bag?
No,
Oh, right.
I'm just saying force her into the cas bag, but I am.
Yeah, well, yeah, absolutely.
I'm being totally flippant.
Oh, sorry. I thought you meant doing the quick. Yeah. Yeah. Well, you know. I'm sure some people will. But yeah, I mean, this question. This question really boils down to this concept of capacity and consent, which is a relatively lengthy process to go into, and it also then it's sort of linked in with this idea of the Mental Capacity Act and the Mental Health Act as well. I think from our perspective, what it comes down to is that this lady clearly needs some form of assistance, doesn't she? It's likely. I mean, I could probably dress the question up to suggest that she can't walk or that there's a bit of blood on the floor or whatever. So she clearly needs some form of help. But and there's also a concern that she's not really necessarily taking in what's going on. And so you know, if she was fully alert and conscious and you had no concerns, and you know, she says just go away and leave me alone, I'm making my own way down, they're quite adamant on it and they understand what's going on, then some of these patients, you know, you just have to leave them. You know, we're not, you know, we can't be forced into, no one can be forced into doing anything against their wishes. But this isn't quite the same here. So we're concerned she doesn't have capacity. So just quickly, in terms of capacity, which is more of a sort of a general knowledge point. A capacity, someone's ability, so someone's capacity is judged on a case-by-case basis, and it changes depending on a decision, and it changes. Depending on the decision that needs to be made, and it changes depending on the time. So someone's capacity can change hour by hour, and it can also change being determined by what the question is that's being asked of them. And to assess someone's capacity, we need to essentially assess four components. Do they understand what's going on? Do they can they retain the information for long enough? Can they weigh up the pros and cons, and then can they feed that information back to us? And if they fail any of those 4 points, then you can deem that they don't have capacity. So if they claim to understand it, they retain all the information, and then they understand it, they weigh up the pros and cons, and they feed back the information, feed back the answer to you. In 5 minutes' time, they've forgotten it, they don't have capacity. If they understand it and they retain it and they weigh up the pros and cons, but they can't communicate their decision to you in any way possible, whether it be by written or voice or whatever. I know it's a highly unusual scenario, but they clearly don't have capacity. And this is more just about if you come across a situation, and it may well be that it happens on a search. It would not be unusual if you've got a search where you're finding someone who's despondent and who, for a variety of medical or psychiatric issues, they may not be able to, or may not wish to comply with your request of coming with them for assistance. You just need to think twice and be like, is everything normal? Is everything right? And if not, go back to the team leader, and it may become a matter for the police who can use different powers to control the situation. It's a bit of a complex topic. There's lots of things to talk about, including mental health apps and stuff. But roughly, does that kind of make sense? I don't know, Dave, if you've got anything you want to add to that?
Yeah, it's the kind of area. Sorry for being flippant earlier, but I don't. Just got back to the mic, but it's the kind of area that is always one of you almost doubt yourself sometimes. So we will always get corroboration from another healthcare professional, or in mountain rescue terms, another team member. It's the kind of decision that's very difficult to make on your own because of the potential consequences.
Yeah, no, I think that's definitely a very fair point. What have we got here? A couple more questions. A few more clinical questions. 18-year-old female, known diabetic, appears confused. What to do next? And funnily enough, different teams answer this question differently because different teams have got different kit. But what would you do?
I'd give glucose orally on the basis of you're not going to really do any harm. If it's something else, but if it is just a low sugar episode, you can fix it quite quickly.
Yeah. So could it be a high sugar episode?
It's possible, but I believe giving that amount of glucose isn't really going to make any clinical difference if that's the issue.
Yeah, I think that's a very fair point. Very low blood sugars or very high blood sugars can present with confusion. Low blood sugars can occur over the space of about 15 minutes. Very high blood sugars can take much longer, sometimes even days, to present with real sickness. And the treatment of very high blood sugars is a very complex treatment. Sort of program that has to happen in hospital. They're often very, very sick, and there's a lot, sometimes they need in excess of 7 or 8 litres of fluid being poured into them, and they need a very complex insulin and glucose drips. Low blood sugar is a medical emergency that it can be almost immediately treated in the field. And if you've got young groups of people who are tramping across the hills on a variety of school trips, there will be type 1 diabetics, and you can guarantee that a significant portion of type 1 diabetics, and type 1 diabetes is a significant medical problem that people have lifelong. Often when teenagers get diagnosed with this, they can really struggle to get their head around it, because it's a young and carefree part of their life, and they've been told they've got a significant disease that requires lifelong treatment. And there can often be some psychological problems that can develop as a result. The long and the short of it is that young people can often, there's lots and lots of very well controlled young diabetics, but very sadly some young people with type 1 diabetes really struggle to control their blood sugars, and it also means that if they're tramping across if they're tramping across the hills using up more sugar than they might do, it's easy they could go hypoglycemic. One would assume that their school group would be aware of this and would be monitoring it, but it's something for us to be aware of. It would be an easy clientele for us to receive.
In that one though, Patrick, is for exam question purposes, for the time it takes to take the BM, wouldn't that be more appropriate?
So don't forget that glucogel is in your group 1 kit, so you should all be carrying that. So you could be on scene 30 minutes before your BM kit. The other thing is to consider that teams like Abu Dhabi, they don't actually carry BM machines. So I'm hoping that for the purpose of the exam, that they will be taking that into account. And I think that what I'm trying to get to with that question for the exam is this idea of don't give glucose until BM is checked. So it's this red flag that it mustn't be given until we know a number, regardless of what the there's a bit of leeway. You're right. If the bag arrives at the same time, it would be silly to not wait and do it, wouldn't it? So I completely agree with you in practice.
Yeah.
Right. Okay. We've got 2 more, which will end me up in time to be in the good books at home. So, 50-year-old woman out on a walk felt dizzy and sick. She sat down and struggled to mobilise. When you assess her, she's got reduced sensation in her arm and reduced movement. What's the best plan? And what do you think's going on?
Urgent evacuation.
Yeah. Okay.
Let's say Dr. ABCDE.
Me.
And you can rule out the oxygen because that's wrong, isn't it? 10 litres a minute isn't right for any answer.
Nice. Okay, I like that. Yeah, so that goes back to the. So let's get rid of that because the dose is wrong. For aspirin. Well, what do we think is going on here?
So actually, I'm going to change. Well, this is one of those questions, isn't it? So request urgent evacuation and then ABCD, because I think she's having a stroke.
Yeah.
Okay,
If it said request evacuation, I think I'd have gone with that.
Request evacuation, yeah, would be. I misread it.
Okay. Yeah. So this is worded in a way just like the exam question will be, to try. A number of people will write urgent evacuation, but the right answer is commence ABCD assessment, because although it sounds ridiculous, we're not coming back to learn something in ABCD. I mean, we are, but it's for the exam. This is a sort of pedantry that we need to make sure we stick with. Finally, this is a tricky one.
None of them.
So, what would you like to do?
Load and go. Getting warm.
Mm,
And give glucose, actually.
I need to read the question now that everyone's
So I guess
okay.
it's a tricky one because there's no option there to breathe for them technically.
Okay.
and again, I always start with these: is rule out what's clearly not true or not right. So, call doctrine life extinct. That's not going to happen, is it? Because there's still some signs of life there.
Yeah. Okay. Good. I'm happy.
They're not dead till they're warm and dead.
I'm happy for us to work through it like that way.
Yeah.
The rewarm, they have a pulse rate, so it doesn't. They're not pulseless in this situation.
Okay.
Again, would you do CPR if they've still got some signs of life? Probably not. Glucose orally, I think we're way past that, aren't we?
Okay.
I know you've got to be careful with hydro. Trying to get words out. Hypothermic patients.
Yeah.
So that's the carefully lie horizontally is the clue for me in those set of answers.
Okay.
Transport to hospital for rewarming. Because you can start rewarming on the hill, but somebody that cold, you're not going to really fix them on the hill. So best bet is to get them out, isn't it?
So, Mike Waters is going for that. Mike Jones, what are you going for?
Yeah. If I can take out if I can add my own rewarming in, and the bottom one, I think I'd do a bit of that one.
Mm.
If you can what? Sorry.
We can add rewarm. If we can add, do it. He doesn't say we can't do our own rewarming in the last one.
Okay. Okay. Yeah. Okay.
And strikes no CPR because if there is no signs of life, then we could start CPR. At the moment, they have signs of life.
Okay. So I would say that the correct answer here. I'm just having to just double check a few things. So sorry, Paul. Do you want to say something?
No, I was only going to say I sort of concur, really, but there's something in the back of my head about this lie horizontally business. I'm not quite sure it is, but that's the one I would have probably gone for.
Yeah. Yeah.
So I know hypothermia and cold, and if your blood's cold and it's been lying there a long time, and you start moving around rapidly, cold blood into heart is not good for sure. So that's the reason for doing that. But I don't know why. It doesn't say you wouldn't rewarm them. It says you could, in that last one, you still could be rewarming them, but also taking them to hospital for rewarming. So
I'm thinking that he's actually, although he's not in a good position, he is actually still alive and he's been in this condition. If we start changing that dramatically, it could introduce further complications. He's young, which might indicate that he's closer to the age where they survive better with severe cold. So I'm going for the last one as well.
Okay, so we've got consensus. So yeah, I mean, it is a tricky question. I agree that the answer is the last, and let's go through them. So this patient has got. I'll just move this. Is that coming to my screen? Yeah. Have you can see my Word document? Hover.
no.
No. Okay. So this patient has got. I can't quite find my. Hand up. My. There's a PDF which I'll send around tonight. But essentially, this patient has got stage 4 hypothermia. Okay. So if they've got any form of pulse, if they've got any form of sign of life, regardless of how slow the pulse, regardless of how slow the breathing, if we think the mechanism of injury is cold, which we do here, because there's no trauma, they're clearly dressed in a way that, so that the casualties have been found huddled behind a rock, so probably sheltering from the cold. They're dressed in a way that they're going to get cold quickly, and once they stop, they're going to get worse. So they've probably come to harm because of the cold. They've been found with minimal signs of life, albeit signs of life. So they fit into the stage 4 hypothermia, which is basically, essentially, seemingly dead, but with any pulse or respiratory rate. So they'll be completely unconscious, and they may have a pulse rate that's very, very slow. You have to feel for a long time to feel the pulse. But it's important that you do continue to persevere and try and find that pulse. So in these patients, if we call that patient life extinct, well, all our hypothermia training is completely out the window, because this is one of the few patients who actually trained to hopefully never see, but we can make a big difference. So this patient isn't dead. This patient, if they were warmed in a stable situation, could come back to life and lead a completely normal life. Rewarm on the hill and call extinct. We're not going to be able to rewarm that casualty on a hill, so there's no point in trying. And if you are going to try and rewarm them in a facility where you've got more than just a Cascare and some heating pads and then a bunch of people surrounding the decent. Yeah, that patient needs to be probably on an intensive care unit or being referred to for some kind of advanced life support, like called ECMO. Commence CPR into a hospital. Where they've got a pulse rate, they've got signs of life. This is the body's physiological response to cold, so we don't need to commence CPR. The body doesn't need a pulse rate of 120 beats per minute because it's reacting like this because of the cold. Give glucose orally. I agree, it's not going to do any harm, but as Mike said, it's probably a bit far for that. So by all means give it, but it's not going to really make much of a difference, is it? But you may well give it at some point if you're particularly inclined to. Also, it had to be buccal, wouldn't it? It wouldn't be able to swallow. Carefully lie horizontally and transport to hospital warming. So Paul's back of his mind memory is quite correct. You don't want lots of cold blood sloshing around in a very irritable heart. The heart becomes very irritable when it's cold, and if you get lots of cold blood sloshing around, lots of pressure changes, it can trigger dangerous heart rhythms. The question is that Mike's made a very fair point. Do we start breathing for them? Do we start rewarming them? I'm not an expert in this area, but looking through the document that we have, is that this is the body going into a physiological state because of the cold. It doesn't need a respiratory rate any quicker than it does because it's basically gone into some kind of hibernation type state. This is really bad physiology discussion wording, but that's how I would phrase it. So I wouldn't necessarily be trying to get you to breathe any quicker, but I don't think there would be harm if you were going to do it, to be fair. The reason why the respiratory rate is so low is because the body's demand for oxygen is basically dropped off. It doesn't need any oxygen because all the metabolic processes in the body are completely shut down. And then there's question, well, if we start to rewarm them, so I think that Dave's point about you're taking a theoretical point of stability. As soon as you start to warm them up, you run the risk of potentially causing more problems. Now, would you start to? I mean, you would clearly protect them from the environment. So get them wrapped up, put them in a CAS bag, put them in a wind shelter, all these things. But I think what we're not going to start doing is sort of aggressively rewarming them. I'll look at the document and I'll get back to a closer answer on that to see whether I can give you any more insight as to what kind of rewarming we'll do on the hill. But essentially, the purpose of this was to say that patient's still alive. Let's do very simple stuff. Lie them horizontally because they're really cold and tipping up and down could make things worse. and just get them into a hospital very, very quickly, where lots of things can be done to them. And the outlook is probably quite reasonable if that's done swiftly. Any questions?
The only reason I was questioning it, Patrick, was because it's probably the only one I have done a bit of research on previously. I think it said the algorithm said. I was trying to find the latest algorithm. That's because I know this one changes a lot. And I'm sure the latest one possibly said heat pads to the chest and head, not directly on skin. Was our
So I've actually got those notes written down. So I think it would be fair to say that relatively simple. Okay, I'm more than happy to say that that question could be a lot better, and it may well be that some simple warming things like heat pads may well be advisable, and I'll have to check the guideline myself.
Cool.
I will send that round either today or tomorrow if that's okay to everyone using it.
Yeah, it's the one that really confuses me, because it feels like it changes quite a lot, this one, and I couldn't find what the latest guideline was.
Yeah, I've had these documents floating around, and